So Brooklyn Community Housing and Services, we are a supportive housing organization, and we provide a range of short-term transitional and permanent housing for about 450 people a day who used to be homeless. And we serve a range of different populations, from mothers with children to single adults with a mental illness, ex-offenders, veterans, and people who are aging. The program that we're going to talk about today is housed in our permanent housing SRO called Oak Hall. And that is permanent housing mostly through the New York programs. And we provide housing for 74 individuals who used to be homeless, most of whom have a mental illness. In that program, we are providing specialized services for seniors. And it has been extraordinarily successful since we started. We started the program in 2006. The first year when we started, the seniors at Oak Hall had experienced 415 inpatient days of hospitalization related to their medical needs. And last year, they experienced 35 days of inpatient hospitalization related to medical needs. Same number of seniors, many of the same people, and certainly the same level of need. The basic components of our model at the program are geriatric case manager, part-time nursing services, so we have a nurse who is there all day, 1 day a week, and then some additional nursing services that come in and out throughout the week. Expanded hours for our clinical consultant to work with our aging in place population, a weekly wellness group that's run by the staff, and a variety of other sort of ad hoc health and wellness activities that take place both specifically for that population, but also throughout the agency where the aging population is strongly encouraged to participate. In addition, the aging program dovetails very much with the agency's approach, where we place a very high priority on socialization and community building activities. Along those lines, most of our housing is set up as shared living, so that the people in our SRO, including the seniors who participate in the geriatric program, they have their own bedrooms, but they're sharing a living room, kitchen, and bath. And as we'll talk about probably during the Q&A, but similar to what David was saying, it's that socialization component that really helps significantly as people are growing older. We started the program in a very simple way. When I started as executive director in late 2005, I sat down with the program directors, as anybody would coming in, and just said, what are some unmet needs and what are some changes you may be seeing in your programs or in your populations that maybe the funding hasn't kept up with, or maybe the basic contracts or program models haven't kept up with. So the two things that came up repeatedly were that, number one, most of the programs were seeing a much greater proportion of ex-offenders in their population, and that group brought with them some special needs. But the second thing that came up consistently was the aging population, that more and more people were seeing a greater proportion of their caseloads being individuals who were 55 and older, and that was bringing a much greater level of need. Obviously, the biggest need was medical and health issues, but as we talked about it, one of the real needs was mental health and emotional issues, adjusting to the aging process. As people were getting older, they were seeing their peers pass away more frequently. They were seeing family members pass away more frequently. And this was creating a lot of disturbances for people. It brought up fears of their own mortality, and they didn't quite know how to process it and how to handle it in a healthy way. So what we tried to do was we looked at the data, and sure enough, what people were telling us their experience was proved out by the data. Just between 2000 and 2005, we had seen the agency's population of people 55 and older grow significantly. So in 2000, 15% of our residents were over the age of 55, and by 2005, 33% of our residents were over the age of 55. And in Oak Hall, it was up to 40%. So there definitely was this movement happening, and there definitely was a need that we saw. We started to try to fundraise to see if we could enhance the services beyond what was being provided in our city contracts, and we were a little bit more successful than we thought we were going to be, not quite as successful as we hoped we would be, but successful enough that we were able to add a case manager position and then enhance the services in a few different ways. Basically, just sort of briefly, the way that it works on a day-to-day basis, I would describe it, the most essential component of it is sort of case management by nudging. It's, did you go to the doctor? How's your leg? Are you eating right? Why are you eating this? Why are you smoking? Shouldn't you be going to our smoking cessation sessions? Have you been in contact with your daughter? Have you told your daughter that your foot has been hurting you? Have you told your daughter that you forgot your keys? All of those sorts of things. And then incorporating that with a very sort of healthy and positive approach to the issues around aging. So through the wellness group, but also through a lot of the day-to-day interactions. And the idea being really that you're trying to change the culture and the focus from issues that come up and only treating them as a problem to looking at aging as a healthy and positive daily living experience that people are going to talk about in a very proactive way. So in addition to the wellness group, for instance, we have a weekly activity where the residents get together and they have a bingo night, they select movies. And while those groups weren't designed to be limited to the aging population, I think what we've found is that about 95% of the group are 55 and older population. And I think it really happened after we started the geriatric program, because it really took the aging process from one that was, I think, viewed with a lot of fear and trepidation, and one that was only talked about, again, when a problem arose, to one that became sort of a healthy self-image for people, and that people were very proud to talk about. So I'll just give a couple of other pieces of data before I wrap up. Since we started the program, we have increased the frequency of individuals going for an annual physical exam to about 60%. Now, that's not great. Our goal is 100%, and we're hoping, at least 75%. But when we started the program, it was 20%. So we've been able to almost triple the number of people who are going every year for an annual physical exam with a primary care physician. 50% of the aging residents see our nurse at least twice a year, and almost all of them see the nurse at least once a year. And as I mentioned, we've seen about a 92% reduction in inpatient hospitalizations for medical issues. So just to sketch out a little bit of what that means in terms of public policy, we have an outside person who comes in every year and analyzes our data for some of our programs. And they do what I think is a fairly conservative cost estimate of how that translates into savings, given how expensive hospitalization is. So our estimate is that the reduction in hospitalization saves about $300,000 to $400,000 a year in Medicaid costs. And since we've been doing this for about 6 years, it's about $1.5 million to $2.5 million in savings to taxpayers and to Medicaid just by having a case manager and some extra services in the building. I think the other thing, very positive development that has come about because of the program, is that the expertise in aging services hasn't been limited to our geriatric case manager. So by having a program in place and by having a geriatric case manager in place, all of the staff become aware of issues related to aging, become aware of resources that are available in the neighborhood, and that becomes, again, part of the culture of the program, so that people see aging as a positive experience rather than just a problem to be solved.